Morning from Sycamore Crossing. He's in the middle of a story over here about playing jacks. And this is what I would call throwback week here. Freezing to death up here. It's beautiful outside, but there's a big black cloud coming, so that's why we're indoors. And then talking about throwback, I just wanted to show this. What is that right there? What is that?
Well,
YSL. Yves Saint Laurent. Now, I know that you probably have clothes in your closet that are much smaller than you are now, that are just laying there.
Yeah.
They're waiting for you to lose weight to get back into them. And I'm pretty sure that some of our wives and some of our producers have clothes in their closet that they're waiting to get back into when they lose weight. Now, my wife told me years ago, save your ties because they'll come back. Now, this tie is 40 years old.
What's the point? Has that come back?
It's making it come back today.
The Nara is back.
Is it?
The stripes are back. And I stumbled on this when I was looking for a sport coat I can now get in, which is not this, in back to the closet. How's that? Throwback, right?
Yeah, I just don't understand how you spun the clothes that are in the closet waiting for me to get there into that story.
This has been saved for so long.
Oh, I get it.
Because it's going to come back. The style will come back, not the size.
All right, so we're going to get into the questions, but I got to say something. Yeah, we're going to get into it. Because I was talking right before he said I was telling stories. You know, when we were kids, I just said, wonder what kids and families do. But power goes out, the internet goes out, and and there's no cable on TV. What do they do? And we would be at the kitchen table, and my mom loved to play jacks, and we would all play jacks. I wonder if anybody even knows what jacks are.
Yeah,
you roll them out, and you got the ball. Boom.
That's interesting.
Right?
The other thing that if you had a pretty good-sized family and you thought it was going to be out for several hours, they'd pull out the Monopoly board and put Monopoly out there, and that way the grown-ups and the kids could all play together. And they had a Monopoly board, and people spent hours and hours with social intercourse and talking with one another over the Monopoly board. You ever seen one?
My
that
dad,
exists,
when we were not, when we were supposed to be doing something or whatever, or we're not doing it or whatever, my dad would yell at us and say, "What are you kids doing? Are you out there playing Mumbly Peg?"
Mumbly Peg.
Yeah. Mumbly, and we didn't know what in the world is Mumbly Peg.
Oh no, we played Mumbly Peg.
He always accused us of playing Mumbly Peg.
Would you ever play Mumbly Peg?
No, I never have played.
You know why?
Oh my goodness!
Because they didn't
Jacks,
want you.
I'm up on
They didn't
Mumbly.
want you to get hurt. Because Mumbly Peg is played with a knife, and you throw it up in the air, and it's a long story. But if you play Mumbly Peg, you could get right through your hand here. But
I missed out on Mumbly
Peg. We had
Peg.
no elbow pads, no knee pads, no bike helmets, and we rode the bikes down the hills like crazy without a helmet. We lived. Soapbox derbies, they didn't have helmets and elbow pads. We slammed them together with a couple of skates and some 2x4s and stuff and raced up and down the streets. I don't know how we did it. We ate dirt, didn't wash our hands.
Mud fights,
yeah. Well, anyway, we're here today.
Well, I can't tell you what all we did.
Georgia Cancer.
We would have to have, the next time we do that, Diane, have one of those warning graphics. Do not try this at home, okay? Or don't try this now.
That's a good way to open today.
What?
Don't try this at home, because nobody would ever try this at home. We're here today, courtesy of Georgia Cancer Specialist, Northside Cancer Institute, to discuss questions. And the very first one of these questions is going to spend a lot of time going over stuff we've gone over before, but from a slightly different angle. And I think it's an interesting question. And so I have asked Dr. Tidman to come in with his reams and reams of scientific data. Not exactly so, but sort of anyway. You ready?
Yeah,
years of experience.
I did see a note to him to actually prepare this morning.
All right. Well, he prepares.
I'm a good Boy Scout.
Yeah, but you got an extra note this morning on the be ready.
Mm-hmm.
Okay, so he's ready. He
But
says.
he does, he does. Can you put up the first graphic? The first one, that lady there? You got that one? Is it up? BKP, before I even read the question here, you remember this?
No,
Yeah, you do.
I probably do, but
Put up the
what am I-
second one.
Okay, what am I supposed to
You're
be
looking at the
remembering?
trainer for the. You're looking at
Right.
the trainer for the Kraken. Where this is the what St. Louis Blues. This is the.
And
This is
she-
the woman at the.
She
Kraken
gave, she gave
She
a
made
message.
to him. That message says the mole on the
Yes.
back of your neck is possibly cancer. Please go see a doctor.
I remember now exactly. She was sitting back there and she wrote that out and put it up
And-
as she was looking at the mole on, yes,
The back of his neck.
Bill,
okay.
as you get into this, I'm reminded of a mutual case you and I handled of a lady who had a melanoma resected and treated, and she was 5 years out and had decided that she was cured. So, wife of a dear friend. Anyway, so she chose to ignore a new mole on the back of her leg, and by the time she came to see me, it was very invasive and had metastasized into her brain, and she died a year later. This is before the quote Jimmy Carter drug, or right as it was coming out. But this is a serious topic.
It is. So anyway, this question here. I got to read the question first. Now that we've introduced it with those pictures, but that's one of the classic ways, and I think I even told you the story about the guy that I worked with who saw a man in the line in the cafeteria at Fort Gordon, Georgia, and he had a lesion on the back of his neck, and he stopped me, and he took the guy over to the coffee pot, to the coffee urn, had him turn around and took 2 glasses, put one with hot water in it and one with ice water in it, and touched the back of this kid's neck right where this lesion was. He couldn't tell the temperature. And he said, well, have you lived in Puerto Rico or Central America? And he said, no. He had a Hispanic name. He said, I was born in New York. He said, no, you weren't. And he had leprosy, and the boy found out after we brought him over to the hospital and proved he had leprosy that he'd been born in Puerto Rico and hadn't gotten here till he was 2 years old. So casual in the line, standing at the supermarket, a doctor can see somebody and tell them, your face is red, you may have polycythemia, go see your doctor or see a skin lesion. So doctors are not off duty anytime. And I guess nurses in hockey games aren't off duty either. Right, Ray?
Well, yeah, and it's particularly embarrassing when someone in the grocery aisle drops their drawers and asks you about their rash. But
Yeah, that's a little different than casually seeing something.
Clean up on aisle 3.
All right, now, my wife has had 3 malignant melanomas removed in the last 9 months. Now, this is something new, all right? She is 65 years old, and a maternal aunt had melanoma. She was raised in Florida and burned many times before college, but none since. Now, we've said before, you only have to be burned to the point of blistering 5 times before the age of 14. She'd been burned many times before college, we assume many times before the age of 14. She has had no other skin cancers. Now, I've had melanoma, but I've had 25 other skin cancers. So she's only had 1 skin cancer, even though she used to be burned a lot. And no other health issues except, now it's kind of interesting that he puts these health issues in here, which are pretty serious, but really don't have anything to do with your skin. Morbid obesity, sleep apnea, high blood fats, and blood pressure. So those are all apparently well cared for. The dermatologist is good, and he sees her every 3 months. I had her see an oncologist. Now, that's probably a worthwhile thing to do, even though 3 superficial cancers where they didn't do much more, the oncologist isn't going to do anything, but I can understand his concern. 3 in 9 months, that's a real number. Who said she did not need scans or medications, but he referred her to an ophthalmologist for a retinal exam. Now, you got to tweak your interest, didn't it? She has not seen an eye doctor in 10 years. Now, she's 65 years old, so her vision's not changing now. Stopping at that just a minute, frequently I say on here, even if you have stable vision, you can see TV across the room without your glasses, and you can read your Bible without the cheaters. You need routine eye care after the age of 50 when your vision isn't changing, because retinal things, macular degeneration and pressure, glaucoma, don't give you warning, and you periodically have to see a healthcare professional, even if it's not because you don't see well. So anyhow, she hasn't seen a doctor in 10 years. That meant she was 55. I guarantee you her vision hadn't changed since she was 55. She has not seen a doctor in 10 years, has no visual problems of which she is aware. She does wear cheaters from Walmart, so she has got the little reading glasses and no other problems. Why the eye exam?
Well, let me say this before you start answering. I go once a year for our eye exam. Is that good? Once a year?
Yes.
I go once a year.
The frequent, now that's actually something that if you are wearing contact lenses, then your ophthalmologist is going to bring you back once a year to look at your cornea. And I don't want to get into going to the dentist making you get your teeth cleaned every 6 months, because you don't really need to do that under most circumstances. A stable vision with glasses of that type in a person who is not diabetic, and that's a different thing for you, but if you're diabetic, you need an eye exam every year. If you're hypertensive, you need an eye exam.
Right.
But a guy that's got no diabetes, no hypertension, 55 years old, vision is as stable as a rock of Gibraltar, his glasses aren't changing, about every 2 years is often enough to have your retina looked at and have your pressure measured. But yes, routine eye
But if
care,
you have high blood pressure, diabetic,
yeah, lots of things.
once a year,
Yeah, once a year is good.
because there's underlying things that you're, and the eye exam could tell you something here.
Yes.
So let me kind of interject something here, because Bill and I try to be careful about not overly generalizing and not giving direct medical advice. The point of having a relationship with a primary care physician is to tailor your screenings to know what you need as an individual.
Right.
Because there are lots of different healthcare screenings that need to be done more or less often based upon your risk factors. Here we're talking about melanoma. That's what we're going to focus on today, and there are certain risk factors that say, yeah, you need to be looking more often or more carefully. Same thing with eyes. So there could be other listeners in the audience that have other reasons to go see an eye doctor. They need to see and ask their family practice
like the colon
physician.
cancer.
You can't just say that everything has a checklist. This is once a year.
We
this
can
is once
make
a
a
year.
complex matrix and people can figure it out for themselves, and I'm not dishing
But
that.
a relationship.
But your relationship with your doctor says, okay, which exams do I need and how often do I need them?
You know, once we have that relationship, if I need something once a year, or you want to look at it every 6 months.
Yeah, or every 2 years.
Right,
Or-
exactly. Okay.
Alpha, do you want to put the guy on the scale?
Get back to the question.
Put up the next one. Okay, I'm going to let you spend a minute or two at this, because this is important, that different people have different exposures to the sun. So we'll just do a little quick thing here. Now, they're giving you 6 skin types here, but the first two say, first one is always burns and never tans, which is a very white skin. Second is white that always burns and has a minimal tan. White to olive is burns minimally and gradually tans. Well, I'm in this white always burns and minimal tan group, and I was without a shirt for 20 years as a kid in South Georgia, and that's where all my skin cancers come from. And then the rest of these are darker. So pull that down. We're still talking about risk factors for melanoma. Now pull up the next one. That's the one that you're familiar with right there, right? Well, this thing right here is 3 lengthy pages. 3 lengthy pages of risk factors for the development of malignant melanoma, and of those 3 long pages, how much is related to sun exposure? 1 small 4-line block, right? Mm-hmm. What are the rest of these? Genotype, you don't need to try and learn how to say that. And family history,
Right.
and the presence of other things. So pull that down. So this is a lot more complicated, really, than just how much sun you've had, or just how light is your skin and the burning. Those things are not modifiable. So you were born with those. So the advice that your primary care doctor is giving you is for the modifiable things that you can wear a hat and use sunscreen protection. Make sure your kids, my daughter lathers those kids up because all of my family's got light complexion. But you can't change some of those. So now he also took a history, right? He took a history. And this woman's aunt had a melanoma. We don't really know whether if they went into deep history, 2 or 3 others of those generations may have had them, but at least we know the aunt had melanoma. We don't know about other cancers, but all those things have a risk that for a breast cancer in your family would make you more liable to have a melanoma. Okay, you with me?
Mm-hmm.
Okay, we're going to quickly throw this big thing up here, which is also 3 pages long. But we know that these 3 melanomas, or we're inferring that these 3 melanomas removed in 1 year are all real superficial, because he does not say that he went back and had big excisions, had lymph nodes removed, or had any other thing done. So when you start looking at what you're supposed to do with a melanoma, you've got all of these things here. How deep is it? How wide is it? Blah, 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 blah. And this also is 3 pages long. Pull it down. Let's make it really easy. Everybody likes a picture, right? You got it? Okay, now, this patient's melanomas, I guarantee you, are all stage 1 or 0, because 3 of them in a year, it sounds to me like she's going back every 3 months and 3 of these 4 visits have had a biopsy. Wouldn't you agree to that, right? The way if you're interpreting that? So there's never been a malignant melanoma that has recurred whose depth of penetration was less than 0.76 millimeters. And 1 millimeter stays within stage 1. I wish they'd pulled it back to say 0.76, but they didn't. So pull that one down.
Let me digress on that for a second. So you're talking about histopathology, or you're talking about the surgeon, dermatologist, took the lesion off, they sent it to the lab, they sliced it up thinly, and they look at it under the microscope, and they see how far the melanoma extends into the tissue, and that's where you get your stage. Well, that's not something you can see from
no. That's clearly post-surgical. There are 2 things about it. One is that people have different thicknesses of skin. The skin on your back is about a quarter to a half an inch thick, and the skin on your eyelid is just millimeters thick.
Yeah.
So the depth, dermis and subcutaneous tissues, has to be factored into that depth of penetration. So it's a little more complicated than that simple picture, because if this were the eyelid versus the sole of the foot, the thickness of the skin would be a great deal different. But we're going to, yes, it's right. It's got to come off. It's got to be in a lab. And the guy looked at it, and it was suspicious. Now, I've had 7 biopsies last year, 4 were malignant. Mm-hmm. Well, they were all biopsied because we didn't know were they malignant or not malignant. None were melanomas this particular year.
And the emphasis being here is that the histopathology, the depth of the lesion, the penetration, is what decides how much further you're going to look.
Correct. And how wide you're going to go when you take it out, and whether you're going to do lymph nodes. Okay, we're now talking about the patient that has dysplastic nevi that could be melanomas, and you don't know till you look at them. Now, put this next one up, because these are unusual looking dysplastic nevi that are technically exactly the same in terms of risk, but they don't look exactly the same, do they? That one looks like a cherry, and this one's flat, and that one's round and black, but they are all the same under the microscope in terms of their risk. Put up the next one. Now, I guarantee you, when you go out to the marina and you're putting gas in your boat, and you sit there for about 30 minutes, and kids are all coming by with their shirts off, you're going to see a back that looks like that, or a stomach that looks like that, but you're going to see somebody that looks like that, that's an adolescent. This one is 18 years old. This patient's 18 years old. And most people would just say they got a bunch of freckles or moles. Unless they're seeing a pediatrician or a primary care doc, or unless their mama has a whole lot of education and information, this kid doesn't know that he has ticking time bombs on his back until his doctor or his nurse practitioner or some lady at the hockey game or some doctor put gas in his boat tells him and his mother that that's not normal. Now, I'm going to stop there for a minute before I show you these next.
All right, but stop right there, because you said something, you went to adolescence. We were talking about someone older a minute ago. Now you went to adolescence, and you said ticking time bomb. How long, I mean, could that be something that somebody...
We have no idea with a time duration on that. But
like this woman's 65. She's had these.
Right, but that picture is adolescent. So,
adolescent.
And you said ticking time bomb. Is this something that this might not develop till they're 50 or 60 years old?
First of all, he probably never will have a melanoma.
And there are not enough surgeons and dermatologists in the world to take off all the melanomas that are on people. This is what we're trying to get across here. There's some judgment that you have to apply here.
The melanotic lesions. Dysplastic.
No, I'm just talking about common moles.
Right. This boy right here needs to go to a competent dermatologist after his primary care doc has seen him. And he needs to have his back photographed, which has been new in the last 20 or 25 years, and it's going to be put into his record, and then probably in 6 months, or if he doesn't biopsy anything now, he'll
monitor changes.
Yes, correctly. We look at that right now. You say it again, because you're bringing me into my next chapter.
Monitor changes.
I'll be darned. Okay, put the next one up. This is a typical what's called a dysplastic nevus. And if you look, it's got different pigmentation on one half than it does on the other. Some of those over there on that kid's back were round, weren't they, or smooth. So this is a typical dysplastic nevus that might or might not be biopsied, probably would not be biopsied. Now, put this next one up there. And this one is not a whole lot different, but one half of that, you got the next one up there? One half of this is a developing melanoma. That half is still this. Now, I'm an oncologist. I don't consider myself a dermatologist. And all I'm going to say to some patient, all Ray's going to say is, this lesion has been changed as I've seen it. And have you seen the dermatologist in the last 6 months or a year? Well, no, I missed last year because of COVID or something. We're going to pick up the telephone and send him to the dermatologist. So that, you understand that right there?
Yes, I do.
Now, that is the situation that this lady is in, I guarantee you, because she had 3 removed in a year. She's probably had dysplastic nevi for a long time. I do not know whether she was in inspection up until then. It was not in the question. But we have the idea that she never had one removed until the last year, and then 3 in 1 year. But what was the question, and what would the questioner ask? What did the questioner ask, actually?
Oh, the eye exam. Why the eye exam?
exam?
Yeah, why the eye exam?
We're not going to try and get too far off the air, but got that first eye up there? You don't think about this, but look at my pretty green eyes, all right? Look at it. It's pretty brown eyes. All right, so that is a pigmented structure.
Right.
And this big old thing back there in the back, that's where we told that guy, go see the ophthalmologist. You might have retinal degeneration. This stuff in the middle would give you pressure. Pull that one down. A little more complicated. Got this one up. This is what you see with this entire thing here is the retina.
Right.
It has a dark pigment in it, and the name of that pigment is
I don't know.
melanin.
Oh, okay, all right.
So it is
melanin.
the same pigment that's
Okay.
in a melanoma.
Okay.
And people with
Okay,
systemic
all right.
melanoma can have
Melon.
freckles or spots in their retina, and Dr. Whaley has one. So every year I have to go see not the Walmart optometrist, but an actual guy who can look at your retina, and this is not something that's without pain, because he dilates your eye and shines a really bright light in there and takes a photograph.
Mm-hmm.
Just like I said, the dermatologist would be taking photographs of this kid's back every year. The ophthalmologist photographs my retina every year, because he's not going to be able to remember from year to year exactly how it looked, right? You kind of want to go back to the same guy because he's been in there before, but he's got the pictures. Oh, okay, I'm here over 3 years, this thing is changing. Well, mine isn't changing. So they're not going in there and take my eye out or think it's a melanoma, but pull that one down. So the oncologist's job when he saw this patient was, one, to say, did they miss a chance to do a lymph node biopsy? Did it penetrate beyond 0.76? I guarantee you it didn't. Did he need any kind of blood tests or scans? And the answer is no. But what was he doing? He took a history and he asked about routine eye care, and he was told, I haven't seen an eye doctor in 10 years. And so he made a referral, or he at least told them, we don't know whether he made the referral or not. I always make the referral to an ophthalmologist that I know has some experience and expertise in looking at the retina of people with the melanoma, and I know that because I get one and I use him. He might not have had much interest in it until I found him and we started sharing patients, but that eye exam in a patient of 65 is 8 years late, assuming she had one 10 years ago. She should have one within 2 years. And the reason is not because he's worried about glaucoma or retinal degeneration in her. The family doc might be when he sends her for routine eye care, but he's interested in if you got a pigmented lesion in your retina or on your iris or the other pigmented things within the eyeball.
So for
So go get
emphasis,
it
let
done.
me restate it. The doctor identified that this is a high-risk patient. Okay, I want to emphasize on a high-risk patient. And she was sent to have an eye exam, and it's no different than being sent or being told to look at her feet. Okay? She's high risk. So the whole body has to be looked at, and that includes instrumentation to look in the eyes. That's the point here. This was identified as a patient who's high risk for malignant melanoma, and they need to be screened thoroughly. That's the take-home message here. Just keep it simple.
Yeah, well, I'll make it a little more complicated. If she's had 3 in a year and has really a lot of dysplastic nevi, the dermatologist really, if they're old school dermatologists, he's going to do his own sort of pelvic exam on the genitalia and the rectum and soles of the feet,
Looking between
the
their
nails
toes,
and
yeah.
up all of the scalp, because there is melanoma risk in some of these areas that you keep covered by your bathing suit. He might say, if you haven't had a GYN exam in the last 3 years, go get that part of you looked at. But the old school guys that I've trained with that were my age, they did all that stuff themselves. But nowadays, I don't know how they would do it.
I was in a store in Zurich this spring, and I saw a young man of Arab descent who had a lesion on the back of his neck, and I asked him whether he had been to a dermatologist, that very thing you pointed out. I asked my friends and cohorts who are barbers, hairdressers, masseuses, to be aware to look at lesions, and if they see something on someone, to say, hey, do you know in your hair here you've got this funky looking thing, and go ahead and point those things out, because we can't see all the parts of our body, and others do, and they need to make them.
Particularly people like us who are blonde and haven't got a whole lot of hair on top of our heads. We need to have it looked at. And I will say that my old barber, that's now dead, I treated him for pancreatic cancer 10 years ago, they had a much more rigid schooling for barbers in the old day, and they did do they had skin teaching as part of their barber college. I don't know what barber colleges are like
What they
today.
teach them now. Well, listen, if I can digress, since Bill's brought it up several times of what a bunch of Scandinavian genes he has, I have a funny story. It's a true story. You know, I like to sail.
Yes, you
And
do.
one of my residency days, a bunch of us went sailing, and one of the guys that went sailing with me is, I think he may have become an oncologist, Dr. Mark Morrow, if you hear this, was on the trip with us. And Mark, I don't think he had any tanning ability whatsoever, but he did have this other special ability, because the first day he forgot to put suntan lotion on the tops of his feet. And then the second day, he missed a shoulder. And then the third day, it's like he missed this side of his face. So by day 4,
He was spotted.
he was looking pretty rough. I mean, he looked like some sort of diseased animal. And I said, Mark, what the hell are you doing here? And he says, well, Ray, I'm power tanning. I just tan one area at a time. And I said, well, good luck with that. So, they looked like they had some sort of god-awful disease.
What do you say? We got another question.
Let's go. All right.
But wait a minute. And time is limited. But what do you say to the person that says, where's your sunscreen? You say, what do you say to that person? You say, where's your sunscreen? Did you forget your sunscreen? And they look at you and say, I have never had a sunburn in my life.
Then they're in those middle groups there toward the bottom. And actually, there's a great deal of difference. And we would still recommend they use sun protection, but it's not near as important.
Mostly for aging. I'm married to one of those people. She changes races. She goes out and get in the sun. She's a different race.
So it.
Holy mackerel.
Well, or become,
Right here. I mean,
well,
all right, let's go to the
becomes
next
a little
question.
Latino looking or something, and it's just, or Mediterranean, Italian. They tan beautifully.
Yeah.
And the sun will give them wrinkles just like it gave us, and they'll have a less chance of getting melanoma.
But
Okay,
they wear the suntan. They wear the block just to prevent the age. But now listen, I don't want to poo-poo going out in the sun, but going out in the sun's a healthy thing. We need to be out in the sun.
we be outdoors. I expect you to. After you've done your 1 hour walk, then you can go sit by the side of the beach. All right. Now this patient we've discussed before, and I remember the previous discussion. And when we come up to the insurance company in a minute, you'll get this. It's a pretty lengthy question with a short answer. You've discussed my sister's breast cancer before. She is 70 years old. Now listen to this. She has had breast cancer since 1992. So that's 30 years of breast cancer. She had her first recurrence in 2001. That's 21 years ago. You have reviewed all the chemo and all the hormones and targeted therapies before on your program. Now, you may or may not remember this because of the next question, part of it. She has had a big recurrence in all of the skin from her breastbone to below her rib cage that is bulky and warm, but does not show up on PET scanning. And there is no longer any disease in her liver, lung, or lymph nodes, and she has had recurrences that were biopsy proven in all of these places in the past. So in 21 years of metastasis, she's had a really good response. You commented that her very high progesterone and estrogen receptor scores were signs that correlated with her long-term response to hormonal and targeted therapy. When you last discussed her, this was, I think, about 3 months ago, if I remember correctly, you agreed, the oncologist had said, to give her a Braxane as therapy. Now, I'm going to show a slide in a minute you're going to remember from that. See, remember that one? Mm-hmm. You better remember that one, or I'm going to have to get you a memory pill. All right. But her insurance company insisted that she take Taxol first, even though she had Taxol 3 separate times as part of her previous chemo combinations. She is on Taxol now, but just started, and we do not know if she will respond. today, the oncologist mentioned a HER2 combo drug with chemotherapy attached to the HER2. Now, this patient, when we reviewed her before, was called HER2 negative because all of her treatment had been hormonal without any antibodies. Remember that? Mm-hmm. And we discussed triple negative, triple positive, and we discussed positive estrogen, progesterone, and HER2 negative. Remember me having all the triple positive? Remember that, right? Okay. Her HER2 was equivocal. He says this new drug is for low HER2 patients. Well, equivocal means it was sort of positive but not positive, so it's got some HER2 in it in low number. And might be a good bet for her. I can find nothing about it. Do you have any idea about this? And the answer is yes, I know about it, and yes, I've got something to say about it, but the reason that you can't find anything about it, you could find something if you look in the right spots, is that you're talking about a small, not a small, but you're talking about a limited slice of patients that if you have HER2 positivity, you're going to get the HER2 drug, and if you're flat negative, there's no role for it. So you're talking about that limited group that have some but not much. Okay, put up that next one. You remember this one? What's that say?
The milk chocolate melts in your mouth, not in your hand.
Okay, the M&M, remember?
Right.
So I told you that Abraxane and several other drugs, we have adriamycin that's wrapped up in a candy wrapper called Doxil, but some of these very powerful drugs, irinotecan, Taxol, adriamycin, all come in a form that's wrapped in a wrapper, so to speak, like the chocolate in an M&M, pull that down, so that the toxicity of the drug can be minimized by the wrapper around it, and the wrapper around it, and I'll show this in a minute, fixes to the cancer cell, and then it penetrates the cell before the wrapper melts in your mouth and not in your hand, so that wrapper keeps it from unwrapping while it's in your bloodstream, where it could be toxic to your blood count or something. Now, this is a pretty impressive picture. I'm not going to show it long, but you see how bright red this is all the way up to your neck and all the way down to the belly button there? Pull that down.
Yeah.
That looks hot, looks almost like a sunburn, and it's thick. So you could see that the content of the skin had changed a lot. It was thick. That's what this woman has, and it doesn't show up on PET scanning because it's at the skin, and the skin doesn't have a good blood supply that would make that dye, that chemical in the PET scan pick up. Like, you have to have a good blood supply, like the liver, the lung, and so forth, for it to be positive. This drug, put up the little sign next to them. This is not. It's got a long name in it. That's not Keytruda, is it?
No.
No, what is it? It's in HER2. That's another fancy name for
in HER2.
Yeah, it's another fancy. But if you look at what it really is, it's called famtrastuzumab deruxtecan noxi. Pull that down. So anyway, just
right there,
Say that 3 times in a row.
right there is where I leave the class and change my major.
Okay, but just you don't need. But just so anyway, just imagine that this is a antibody that we've talked about for 20 years or 15 years, 7 years or 6 years on this program, that specifically binds to this genetic mutation called HER2. And it is, pull up the next one. You can use this in breast cancer, colorectal cancer, stomach cancer, gastric cancer, non-small cell lung cancer. Look at that list. That list is 3 pages long. Pull that down. Because all of those cancers have a small proportion of them that have a little bit of this HER2 gene on them. And it doesn't take a lot of the HER2 gene. It just takes enough HER2 gene. It's like you have some Velcro, You got a long strip of cloth and a hunk of Velcro that's small in the middle. Well, they stick something to it, and that whole piece of cloth will be stuck by that small piece of Velcro. You got that?
Right.
Okay, so let's look at the next one. This is, you see in this one? This is that, you got it up there? See that right in there, that's the chocolate around the drug right there. And when that thing hits the edge of a cancer cell, it doesn't require much Velcro or much HER2 on it to stick to it. As soon as it sticks to it, it's sucked into the cell. Then it melts this away. See, melting it away? Mm-hmm. And then the chemo that's hooked to it, that's a chemo drug hooked to it, kills that cell. And then when it kills the cell, it's free, right? Because the cell's gone, and then it can go over and kill another cell. So pull that down. So it's not like it doesn't have any toxicity, but it has much less toxicity because it never got in the bloodstream to just circulate.
Right.
It releases itself in the cancer cell, and a little bit of that get into the bloodstream. But so it just dramatically diminishes the amount of toxicity. This patient's insurance company denied her the use of that drug wrapped around a Braxane or wrapped around Taxol, and wanted her to have Taxol first, which is the algorithm, but not in somebody who's been being treated for 21 years, because she's had Taxol 3 times. But it doesn't change the fact that the algorithm the insurance company looks at that says you have to use a Braxane because somebody couldn't tolerate the toxicity of the Taxol. And the oncologist already knew that she'd had Taxol 3 times, failed it or had toxicity to it, and wanted to go to that drug first. So he started her on that drug, and he says, he's gone back and he looked at the thing again and says, well, look, now that we know she's got a little bit of HER2 in there, this other drug, if they won't let us have a Braxane, might be our next step. So that's the issue. Now put the next one on. What's that? That's one of those sort of survival curves that tells you the benefit of the addition. So if you take this drug and add it to what other treatments this patient is getting, it increases by 36% the response rate and the longevity and the control of the disease. Pull that down. So that's a big number, 36%. Many of our chemo drugs, the things that the benefits are less than 36%. So that is a reasonable choice for this patient. What the oncologist wanted to do in the first place with the Abraxane is reasonable and probably should have been paid for by the insurance company. So
Bill,
your oncologist is on the right track. Yeah, go ahead.
Oncologist is on the right track. The insurance company, as usual, is increasing their profitability by denying patient care for which they've paid. How do you, as an oncologist, document in the patient's record that the insurance company is interfering with or is making detrimental decisions to the patient's well-being?
Well, I will say that we don't dance around that. We say that we had a peer-to-peer with the insurance company, explained our logic, and that the contract that the insurance company has with General Motors or whoever it is has these algorithms in it, and that they can't violate that algorithm without violating the terms of the contract they've got with Delta Airlines or whoever it is, and that it's like if you got $1,000 deductible on your car and the limb falls on it, you got $980 worth of damage, they aren't going to write you a check, right? Or if you don't have collision insurance, if you don't have wind damage, you get hit by a hurricane, you got flood damage insurance, and they aren't going to pay. So that you get into then what are the policy limits and the policy descriptions that you have in your health plan through your employer, and other insurance companies would approve the Braxane right off the bat, but it's not the science that they're going against. It's the provisions of the insurance plan. They were able to quote a lower rate by saying that you aren't going to go to this high cost therapy until you have failed the low-cost therapy, and the algorithm can't be argued with, even though you can't argue with that algorithm because that's what they bought. They bought that insurance plan. Now, nobody ever told HR department that there were small restrictions in there, so you basically have to live with it. But you make it clear in the chart, there's no place anybody can sue anybody because that's the way it is. You just don't like it. Does that make sense?
I understand what you're saying. I'm much more in their face. I say, look, you're denying this, and I'm going to document in the chart that you are denying this patient care that this physician deems is life-saving to them, and you may be the cause of that death.
Well,
so it's going to be documented in the chart. So you.
Well, I do that carefully.
Yeah.
They don't talk to me on peer-to-peers anymore because I scream at them, and Justin does them for me because he doesn't scream at them. But
well, let me say that. Let me say this because in the conversation here, I'm reading the question. The word insurance company is in the question. So, how many times or how often? Because when you're seeing somebody or yourself. When you're seeing somebody as a primary care physician, you make a determination how you want to treat that patient. You and the patient are in the room. You make a determination, and you go out of the room, and you have to start through. This is what I want. I want this prescription. I want this. I want this, and then they start coming back, and you have to alter your treatment. You got to come back and sit down with your patient and say, I want to go this direction, but your insurance company's not going to let us go this direction, so we're going to have to alter your care. And we're going to
tell the patient that their care is being denied by the insurance company, and if there's some other way for them to get it paid for, they need to do that. But it has to go back. The patient has to have their agency and make their own decision. They have to know that their insurance company is, quote, screwing them out of care, and that they need to find another way. But the bottom line, and you know, Bill and I joke about he's able to describe how to make that watch at that level of brilliance, and I'm like, what time is it? Okay. It is enough for either one of our brilliances to try to figure out these very complex biological systems and what's going on. Very complex, requires all of our attention and a lot of study. Okay. I don't have time to deal with insurance companies and their complexities and their web of mischief that they use to deny care. I don't have time for that. I've got more things to focus my mind on. And so I make that decision. I'm not going to go there and argue your game. You control all the rules and you change them at will when you want to. I can't go there. I am going to tell you that you're wrong. Okay? And that this, in my understanding of what's going on with this patient, is what they need.
Right. Now let me take one place. I want to make one thing clear. You got chocolate, vanilla, and strawberry, right? They're all ice cream. And I don't like chocolate. And I do like strawberry. So I would, if I were going to prescribe ice cream for you, to try and put some weight on a cancer patient, prescribe you strawberry. And your insurance company has a contract with the people that make chocolate. I really can't argue with that because chocolate ice cream is going to do you as good a job as strawberry, and I usually write strawberry. So if they come back and say, look, you're going to have to use chocolate here because we don't pay for strawberry, that change, I'm happy to make. I'm not happy to make it. I will make it because
Sure.
it's the same thing.
There's no difference.
I can
There's
understand
no
that.
difference. Okay, and that's what I mean by that. These are the generic things, and there are 4 or 5
Right.
different blood pressure medicines that are all in the same class, and that happens in blood pressure all the time. Pretty sure it happens in diabetic medicine. I'm not
Diabetics all
sure.
the
So
time.
that happens to him every day.
Yeah.
It's not, and there are some of those that happen in oncology drugs, but not the one where the M&M is wrapped. That thing is there's no way that the two things are equal. Anyway, so that's.
All right. Well,
All right,
what?
we're getting to it.
You have to go to work, but I know you have something big.
We got something big we got to talk about. You're going to have him for a long time today. We have talked about this long COVID business enough. Like my wife had tasting right, stank smelling right. And we said a couple weeks ago, 25% of people are going to have this issue. It's going to go on for years or even longer. But there was a study. Did you look at this one?
Yeah.
Okay, there was a study that was done in Europe, in England, to try and figure out why some of these long-haul COVID things are lasting so long, and there's no predictability about who's going to have the long-term cough and shortness of breath and the infiltrate in the lung, or who's going to have the long-term fatigue. And what they are learning is, and this goes to some of the stuff that Ray's talked about the vaccines, is that small particles of the COVID virus body, just little pieces of RNA, can get into cells and induce an immune response that will last beyond the life of that
infection.
The life of that little fragment. It's gone away. And that's where a great deal of the argument about the present vaccine versus old type of vaccines come along. And I'm not smart enough to know what's going to ultimately show up in 2, 5, 7 years, just like thalidomide or anything else. We don't know what the long-term responses are going to be. And my wife is convinced that we're all of us that have these shots are going to die and our hair is going to fall out. And Steve Marlowe is convinced that everybody that doesn't get the shots is at increased risk of dying. And the truth's got to be somewhere in the middle. But what that did show there is that this virus is a little bit different. This is activating the Epstein-Barr virus, which is associated with multiple sclerosis and Hodgkin's disease.
And chronic fatigue.
Chronic fatigue. Yeah, I forgot that one. That's the top one. It's activating the herpes zoster virus. It's activating some common cold viruses. So this little fragment, when it gets into the cell, can activate some other viruses that have been asleep in your body for 50 years. And it's really complicated. And none of us know the real answer, right?
Right.
And that
None of us know the real answer. None of us knew the real answer, and a lot of people came out and acted like they did and said, "This is what you have to do."
And by the way, the CDC really came out 48 hours ago and says we're going to completely revamp the CDC because we failed in our mission, and this 50 years we've been waiting for this pandemic and we screwed it all up. They're going to try and, just like firing the general manager, firing the coach, and firing the assistant coaches, and going back to rebuild a football team. I mean, basically, they say we're going to rebuild the CDC.
Well, they're going to have to clean house, and
exactly
this Maricopa is $1 a day late and $1 short.
Yeah, but that's what they said. They have to rebuild the CDC, how it operates, how it thinks, and everything about it.
Well, as clinicians, I can tell you that is just the window opening of what a massive amount of nonsense has gone on, and you can just see it's going to come out in the next month or so. Because for them to say,
some of that stuff will take a while.
Well, no, it's going to take a year or so, but I'm just talking about the cover-up. I'm talking about the nonsense. The stuff that was completely inappropriate and unethical is going to start getting exposed now. So pay attention. There's going to be information coming out, and everybody's affected individually, and there's no one solution to it all. But at least finally, the doors are opening and the lights are being turned on.
Right, but when the CDC says we totally screwed up, our system is not organized correctly.
Yeah.
We have emphasized academia, and we have emphasized non-practical things to the detriment of our ability to interface with the world. They're basically saying we got a terrible football team, or we're going to have to start at ground zero and rebuild it. And that's my analogy. It is exactly like they fired the general manager, the head coach, and all the coaches, and they got to go out and start recruiting new players. And it's like Georgia Tech. They're going this in the fourth year rebuilding, and they still aren't winning. So
what we went through, and we got to close.
We got to close.
Just to say, is not appropriate or not acceptable. And what we're all taught to not rush to judgment, we allowed people that we're supposed to be able to trust to do both of those.
Yeah, my analogy being an aerospace engineer is that when you see the space shuttle blow up, okay, and they come in and say, well, we got to shut the whole thing down We got to go through every process and every person and everything that went on that let this happen. That's the proper ethical response, okay? We've had a space shuttle blow up in the CDC, and there have been people in there that have been screaming and yelling and saying, this needs to end, this needs to stop, this needs to end, and they've been squashed and shut down. Now their voice is being heard. And the people that have been doing the squashing and doing the politics and doing all the nonsense, they're going to be called to account. But they need to shut the whole thing down, as Bill's alluding to, and take the whole thing apart and say, what went wrong here? And then let's rebuild something that works.
The shuttle analogy was really good, because
Yeah.
who would have thought that an O-ring who was cold could have done all that? All right.
Let's analyze
thank
that
them.
in the
Let's
next
thank
segment, and let's thank Georgia Cancer Specialist Northside Hospital Cancer Institute for our segment every Friday morning with Dr. William Whaley, Dr. Raymond Tidman, and right after this, hey folks, we might talk a little further and go into more detail about the CDC.
Do you want me to leave you this jacket, Ray?
Maybe.
I'm a little chilled. I'm
I'll
going to have to
tell
go in
you,
the sun real quick.
I have to go out. I have to see where they're hanging the meat here. Is this a meat locker? Take a break. We'll be right back.